Go.
Okay, about 10 seconds or so, and then you're good to look. So just use arrow keys to go to the next slide.
Okay. 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 Good afternoon, everybody, and welcome to the second Director's Choice lecture of this year. And I'd like to begin by acknowledging the traditional owners and their custodianship of the lands on which we meet today. And I pay respects to their ancestors and descendants who continue cultural and spiritual connections to country. And we recognize their valuable contributions to Australian and global society. So today, I'm absolutely delighted to introduce to you today Professor Kathryn North, AC. We're very lucky that she happened to be here for a meeting today. So we were so happy that she was able to join us in person. I'm just going to give you, of course, many of you will know Kathryn and will know of her work, but I will give you a biography to let you know about her. So she's here in her capacity mainly, I think, as the president of the Australian Association of Medical Research Institutes. And Kathryn's been in that role, I think, since November 21. But she also has a lot of other roles. And just to summarize, so she's director of the Murdoch Children's Research Institute in Melbourne. And she is the David Danks Professor of Child Health Research. And Kathryn has a very distinguished career, trained as a physician, neurologist, and clinical geneticist. And she obtained a doctorate for her research in neurogenetics in 1994. And then she was subsequently a postdoctoral fellow in the Harvard Genetics Program. She is the co-chair of the Global Alliance for Genomics and Health, which is a collaborative network of over 500 organizations across 100 countries, which is funded by the National Institutes of Health and the Wellcome Trust. And she also leads the NHMRC national network of over 80 institutions known as the Australian Genomics Health Alliance, and the goal of which is to provide evidence and practical strategies for the implementation of genomic medicine in the Australian health system. She chaired the NHMRC Research Committee from 2012 to 2018, and she's chaired a number of other advisory boards, including Great Ormond Street Institute of Child Health in London. And she's a member of the board of the Victorian Comprehensive Cancer Centre, and she's also Foundation Fellow of the Australian Academy of Health and Medical Sciences, which is why she's in Brisbane today. And she's a member of the Academy's board. So please join me in welcoming Kathryn.
Thanks so much, Paul. And this is my first interstate travel talking to people in person. And I know we've got a lot of people online, but it's really great to get back on the bike or get back on the plane and start to travel around again, because I think that's the thing that I've missed most over the last 2.5 years. And I'm sure you guys, as I know in my institute, it's been incredibly disruptive, and we keep trying to restart, get the band back together, and get the buzz back into the place. And the ongoing restrictions make that very difficult. But that's also, I think, reflected in what's happened across the medical research sector over the last couple of years. And I think there are good news stories we can take home from the last couple of years, but I think it's a very important time for us to be thinking about the future of medical research and the medical research sector, and also with a new government. It's very timely for us to be working together to advocate for the future of health and medical research. So what I'm going to do today is really look at some of the long-standing and systemic issues that we face as MRIs, talk about our key policy priorities and the new opportunities with the new government. And I've really planned this just to talk for 20-30 minutes, but leave a lot of time for questions at the end. And really welcome any input you have into how we've put together our priorities as well, because AAMRI is very much a member organisation. We're here to represent our members around the country. And I think it's an incredibly strong sector that I'm very proud to be part of. I think we all know that the pandemic has shown us the value of medical research. And I don't think at any time has there been such a high regard for medical research and for evidence base. There are so many words that are now in common usage. I mean, people know about rapid antigens, they know about PCRs. From my perspective, from a genomics perspective, every day our government would stand up and go, we're waiting for the genomic testing results so that we'll know what to do, which as a genomicist warms my heart in terms of public awareness, even though it's a viral genome versus a human genome, just how it's now accepted into common parlance. So very much part of the national conversation, and really our scientists have never been more front and foremost. It's also highlighted the whole pipeline, the value of the whole pipeline of medical research, from the importance of biomedical discovery at the basic science end of the spectrum, through to clinical trials and clinical research, but very much how that then gets applied at a population level in public health, and the importance of prevention, which I think certainly my work's in pediatrics, and our big goal is in prevention across so many different areas. And we're so used to, in my field, it's often there are small sick children or children receiving chemotherapy, whereas what we're really wanting to achieve is lots of children that are just healthy. We want our adult populations to be healthy, and we have to work out how to message that. I think the other thing around just around the medical research institutes in general, which is I think is something we need to promote much more as a sector, is that our entire focus, particularly with the independent medical research institutes, our entire focus is on being a research arm of the health system. Our entire focus is on research. The other, universities, and particularly here, where the universities are a big part of TRI, but there is a broader remit there, particularly when it comes to education and also the multidisciplinary nature of universities. Whereas medical research institutes are really focused on that translation into healthcare. And I think that is something we need to promote more and more, because it really is what sets us apart from other parts of the sector. And we need to, I see that as a strength and something that strengthens our advocacy, particularly when we're working with health departments. The other good things, I'm very much a COVID silver lining sort of person, because otherwise we'd all just go and sit in a corner and rock. But I think the pandemic has really shown us nimbleness as well, and taught us new ways of doing things. I know in my own institution, we took an idea for a clinical trial from conception through to recruitment of first patients in 3 to 4 weeks. It's something that would usually take 9 to 12 months, but we then developed an entire way of working with our research and governance structure, where they just became part of the team. And that, as we rolled out in this study, eventually went over 10 different countries. We just, it was just an iterative process. And I think all of us will have examples of how much more nimble we can be, and we must not forget how we did that, and to not lapse back into the sometimes turgidity of processes. I think the public health advice and modelling was the quick implementation into policy. When something is needful and there is a crisis, decisions can be made quickly. And I think we also need to turn that thinking towards, again, we've got what are sort of crises that are happening in slow motion around the common modern epidemics of obesity, diabetes, cardiovascular disease, cancer. We should be taking that same approach in partnership with government of how do we help them how do we step up, help them meet those challenges, and how do we act quickly to get policy into place. The development of diagnostic testing, testing tools, clinical trials, vaccines and treatments. It's really been an incredible time for medical research over the last couple of years. And even though in some ways it was the worst couple of years I can think of at my institute, because in Melbourne we had 275 days of lockdown. We got the world record, which we're not very proud of the most locked down city in the world. And that has a real toll on your people. But on the other hand, it was probably the most productive, last year was the most productive year I think the Institute has had in terms of really, very, very focused in our work. I think the medical research sector during COVID has also shown the value of its very close integration with health service delivery, which I think we have to continue. And even yesterday, my institute is co-located with the Royal Children's Hospital in Melbourne. And it was great yesterday sitting down with the CEO of the hospital and some of the senior medical people just to talk about where their gaps were, where their pain points were in terms of how the Institute can help them with their research. And what really emerged is from if you look at all of what we do from the healthcare perspective or from what the hospitals are going through under increasing pressure, what they really want is they want help in terms of prioritizing what are the important pain points that should be addressed with an evidence base. They want help in how you design the study approach to that in a very robust way. So really taking what's usually quality improvement into much more into health service research and implementation science. They want the pathway to implementation, and we all, from our research perspectives, must be thinking much more of, it's not about the paper that you publish, it's about what you do with it, love, as they say in the castle, in terms of getting it into practice and having an impact. And then finally, they wanted our input on how they evaluate in an ongoing way what works and what doesn't work. So I think that's another important thing for our sector to learn, is that, we all have our exciting things that we work on personally from an investigator initiated perspective. But I think we need to have some real conversations with the hospitals that we partner with, because their priorities, certainly currently, are often very different to what we are doing. And we really, I think we can do both, and I think we can do it well. So it's a great time to be a medical researcher. We've got great public sentiment, great political support. And in 2021, again, during the pandemic, continuing pandemic, health and medical research is ranked third in priorities from reviews that were done from government, which means that, and government takes notice of what the voters want and what people think is important, because I think we've certainly seen dissatisfaction with the previous government in terms of the results of the last election, and our politicians remain acutely aware of where public sentiment is. The vast majority of the community expresses interest in health and medical research, and great to see that almost half of the respondents would participate in a clinical trial, because that importance of, one, knowing about the sector, participating is incredibly important, but increasingly we would want involvement at very early stage, particularly in co-design of a lot of the research that we do. that's using the pandemic as an example. We know very well of some of the other great examples of medical research that delivers. So it's, again, we are a sector that's really focused on the importance of medical research and its translation into the health system. And we have an eye on that. But we also deliver, and I think we've demonstrated we're nimble, and we should not make any retrograde steps. We should keep up that nimbleness and that forward thinking. We've got strong public support. Governments are investing record funding in medical research with the full realisation of the MRFF in addition to the NHMRC. So that's the good news. It's all very rosy. What a great time to be a researcher, but we know that's not translating into what it's like on the ground because of a number of systemic issues, some of which have just evolved historically. But I do think that it is a perfect time to be very strongly advocating for change because of all the reasons that I've just talked about. So these are the most important issues where we'll focus, and these are the areas where I'll talk a bit about policy. But what I think is, what I do think makes this a bit of a unique time in history is that often AAMRI might be advocating for something a bit different to Research Australia, to the group of 8 universities. But I think at this time in history, there is a confluence of what we all recognise as the major problems, and hence how we're advocating is really quite complementary. So we've got a very talented workforce, but they're all precariously employed because of, particularly with short-term contracts. Sometimes, successful early, mid-career, even senior researchers do get a degree of certainty, but I was really horrified actually during the pandemic. I really made an effort to meet with all the different types of staff we had across the Institute and found particularly our technical people were just on recurrent, a lot of them were just on recurrent 1-year contracts, which, we're immediately trying to do something about, but it's that inherent nature of the short-term funding that many people survive on. We've had a great investment in health and medical research, but it lacks coordination. NHMRC has not had an increase in budget above CPI for over 10 years, which basically means its value is slashed. MRFF has been fully funded, but we both know those programs are not coordinated with each other. And I'll come back to what are the ways we can fix that. Also, research, the link between research and healthcare, although it's improved during the pandemic, it's still quite fragmented. And as I talked about yesterday, just my discussion with our senior people in the hospital, what their priorities are, and we all see the delays to implementation of work. And that is something that I think we can make some real practical strategies to overcome. So the big thing that we're pushing for, and I think this message has certainly been heard, and it is being pushed across a number of different areas, is we actually need a national strategy for health and medical research, and we don't have one. Many of these principles were talked about in the McKeon review that was delivered almost 10 years ago in 2013. But really nothing has been done in thinking, this is what we want health and medical research to look like across the country. And the 3 areas where we need real national coordination and partnerships between state and federal governments that are both big funders of medical research, but across the research itself and the research priorities, that plan for our workforce. What is the ideal number of the workforce? How many PhD students should we be training? How do we make sure we're developing career paths, particularly in the atypical areas where we really need to grow expertise, but also in our clinician scientists? And how do we coordinate funding so that our people aren't spending around a third of their time doing something to do with grant writing or peer review. So this is freely available on the website. It's a national health and medical research strategy that we put out late last year. And there was sort of a bilateral push for this idea around strategy, for the national strategy, with some specific details put forward by both ourselves and Research Australia. And there was a response to this from our previous Liberal federal government to take that forward as part of what they call Vision 2040, which was how do we develop a longer term plan for what our research sector looks like. And as you know, we've since had a change of government, so we're actually in a bit of a holding pattern at the moment in terms of how the next phase of some of these things that we'll put into place will evolve. So what we called for in our white paper, and I will actually get to a couple of these things later on in a bit of detail, and then we can talk a bit more about it. But first of all, research priorities, but aligning investment and workforce to what the research priorities areas are. And looking at how we align priorities and investment across the NHMRC and the MRFF as, two major complementary areas of funding, one of which is sitting in the more basic side of the pipeline, though obviously the NHMRC funds broadly, but the MRFF has more of a top-down priority-based approach. But what if those two things could be brought together so that there was a really deep funding across that entire pipeline? The clear pathways to integrate research into delivery of healthcare, I've mentioned, and also making sure our structures around research are continuing to promote and reward collaboration. I think there's been a lot of schmozzle with the MRFF where you can't be a CI on more than one application. And that's, to me, is anti-collaboration, whereas its purpose is to try and cut down the number of applications, I think. But we should be rewarding, incentivizing people working together. And to me, the best way to solve the big problems and the big health challenges is to have the best people around the country working together on it, and having co-investment by both the federal and the state governments. That would be, that's the nirvana dream of what we should be working towards. From the workforce perspective, the sustainable career pathways, we don't even know exactly the composition of the health and medical research workforce. Our state government in Victoria has just actually funded us to at least look at what the composition is in Victoria, and then we'll work with the state AAMRI groups around the country so that we at least start to capture what our sector looks like. And we also need to invest more in our clinician researcher workforce. And then the idea of coordinated funding, which I'll come back to, and how that might work. So that's sort of where we're up to from our white paper in November 2021. In March, the coalition handed down a budget. They also put in place or handed down a budget with a new 10-year MRFF spending plan. But what is happening currently, I won't go any more into this, as what is happening currently is that the new federal government is basically reviewing everything that was in the March budget. So nothing is, we're back in a little bit of a grey area. Nothing is certain. The other legislation that went through before the election was declared, so before government went into caretaker mode, was in the lower house. They passed a new legislation about the Medical Research Future Fund that basically ensured that it's around 650 million a year would be delivered from the Medical Research Future Fund, which meant that because the interest rates were so low on that investment of over $20 billion, that they're making sure that that was a minimum amount that would be dispersed. But it was also a capped amount to be dispersed, so that if you got higher returns on that 20 billion, that was still not flowing out to the research community. Because I think the initial goal of the 20 billion Medical Research Future Fund was that it eventually, if you were averaging 5% on investment, that there'd be $1 billion a year would be available from health and medical research. So that legislation is now lapsed. So there is an opportunity for us to re-engage in that conversation with the new Labor federal government to see if we can. Obviously, we like the idea of there being a base cap that's an insured level of funding for MRFF, but it would be good to see if we could, that if there was increased income, that there could be increased investment in the sector, particularly in the areas where things are falling through the cracks, and looking at the complementary funding that's needed from the NHMRC. We now have a new government, a new health minister in Mark Butler, and I met with Mark Butler a couple of times before the election was called, and he has a long experience with the sector. He was around during the McKeon review. He's very familiar with the NHMRC. I think sort of very supportive of the health and medical research sector. So my impression is that he'll also make a really good health minister. And the problem is that currently, as has happened so many times over the last couple of years, the government is a bit paralysed because we're now in new waves of COVID that's taking up all of their time and mental energy. So the business as usual part of running this country now, and pretty much over the last couple of years, is very frustratingly not happening. And so that's what the advocacy we do has to be even more on the front foot. And sometimes I do feel like we're nagging, but I think it's very important that we don't just, everything can't just wait until the pandemic ends, because God knows when that will be. I think this is, as I've said earlier, there's a really good opportunity now with the confluence of the positive attitude to health and medical research, the ongoing health crisis and the importance of evidence and continuing innovation with the sector, a new health minister, a new government, that there are new opportunities. So again, we have to be glass half full rather than continually frustrated. And what I do know is that from multiple different areas, we're all giving the same message to the health minister about this need for reform, the need for a national plan that's harmonising across our sources of funding, and to really have a much more mature approach to how we're administering health and medical research in the country. So during the election, we also put forward our policy priorities for the government, and this is what I'm going to end on in terms of what we see as those main areas that I have already touched upon. So the first thing is we've had MRFF grow up independently and be administered independently from the NHMRC. We've lost the balance of investment across the pipeline from basic science discovery through into clinical work and through into public health. And we have to readdress that balance. We have to have a balance between investigator-initiated and top-down priority-based research. So it needs to be a whole of system approach. And wouldn't it be great if we had if we brought those two things together, of the NHMRC and the MRFF, had a single portal for application, and really could look across that the entire pipeline of research at all of its different stages related to, really high level priorities. I think a really good example is the investigator grants. We really do need investigators across from basic science, biomedical discovery research, right through into public health. But that should be a single application mode co-funded across both NHMRC and MRFF as a starting point. And what then, if we could get our state governments, who all make great investments in health and medical research as well, to co-invest, to leverage and increase the pot, again, rather than the fragmentation that we see, where I think that, again, states, rather than working together, compete with each other. I'm not against competition. I think healthy competition is good, but there are so many things such as workforce issues where the issues are the same for all of us, for all of the states and for the federal government, that we should all agree that we want our best and brightest to be supported. We should all agree that we don't want this fragmentation of systems where, because you sort of have to be in it to win it, you just apply to everything and hope that, the dice come up so that you'll get funding from one of the different sources. I think if we could settle the sector down and so there was a much more more considered and coordinated approach to workforce funding, I think that would be great. Probably the best example is looking at what's happened in the UK, where they've brought together the MRC and the NIHR, which is sort of the research arm of the Department of Health, for this coordinated single, there's a single portal for applications. And we don't need the duplication of administration of research funding, which is now happening with things going back into NHMRC. But NHMRC, which I've worked in as chair of research committee for 10 years, it seemed like 10 years, it was 6 years, that the back of house, the care that goes into, the peer review, the objectivity, looking at priorities. It would be great if we had that sort of, that very objective overview of the way that funding was administered. I think the workforce plan, there's the needs for equity, gender equity and diversity, but I think very much looking at sustainable career pathways. I think there are good models from a clinician scientist perspective that are growing up at different parts in the country, but we need that same sort of sustainable career plan for our non-clinician researchers as well. And I think also looking at what the legislation is around the MRFF and what that funding can be used for, I think there is a lot of other ways that we could get more value out of that investment rather than picking specific diseases and having small calls that are worth $12 million with lots of people scrabbling to put an application in. I think we could, all of that money could be used in a lot more strategic way that's really supporting the best work across the sector. And then finally, we decided to go bold because it was an election. And I think that the rethinking a nationally coordinated approach to health and medical research with having a strategy that's bringing together our funding across NHMRC and MRFF as a starting point, and then incentivising leveraged additional funding from state governments. That's a no cost. So that doesn't cost anything. It's just using what we've got better. And actually, Mark Butler thought that was quite refreshing, that that was the starting point, because that would be a great thing to achieve. But we then need to continue to increase the investment. And so the other part of our the priorities we put forward was to continue that investment to grow the pot. And even think of doing it in a different way. I mean, the Medical Research Future Fund is an investment where the $20 billion sits there and the proceeds are distributed. Wouldn't it be great if we could think of NHMRC in that way as well, so that it was then had a sort of these stable investments that were there to really look to grow the pot of what we're investing in health and medical research. We can't keep just asking as a sector though. We need to be demonstrating the value of what we do. And that's inherent upon us. Knowing how politicians think and work, they want us to help them look at where they can save money, give better care, avoid adverse reactions. And, you know, you do look at the figures and it's probably, I think around 60% of treatments and diagnostic tools used in the healthcare system are thought to be useful. About 30% are, you know, iffy whether they're helpful at all, and about 10% just cause harm. So we need to get rid of those 40%, and that would already save quite a bit of money that could be invested elsewhere, and we should have a role in offering that support to government. I do think that the other thing that we've done from the AAMRI perspective is set up, it's a new website where we gather stories from around the country of the successes of health and medical research, just purely to let people know what medical research institutes are, because internationally, this sector is also quite unique. It's very different in other countries, and yet I think it really, and that's why our identity as the R&D arm of the health system, I think is one that we should be celebrating and really promoting. And we should keep really touting the discoveries that have come out of our sector. So it's the demonstrating what we can do and really being seen as a positive partner for government is the way that we're going to continue to increase the research and the investment in health and medical research. So this is my last slide. There's a lot of opportunities. It's always, you always feel like you're starting again when there's a new government, and the public service changes as well, and it's a lot of turnover, and because so much of this is based on relationships. The MRFF legislation, as I said, that can be re-looked at, and what that also means is that it may be a good time to change how the MRFF is delivered and how the funding is distributed. There's an October budget coming up, and so there may be commitments that were made in the previous budget that might not be honoured, and so we need to keep a keen eye on that. The NHMRC, that certainly even this week, the NHMRC has received a discussion paper around how to improve gender equity in the distribution of NHMRC funding, with some quite bold options, and I'd encourage all of you to look at that, and for either as an institution or individually to participate in that consultation. And the final thing that is sort of the single message that I'm going to be pushing over the next year or so is that we need to have a much more coordinated approach within the sector. And if in the next 12 to 18 months we can achieve a coordination of NHMRC and MRFF so that it's easier to access that funding, but there's a complementarity to that, and similar processes that go into the evaluation of funding applications, and the need to only apply once, so that with it going across both pots of funding, that to me would be a very good start. But that's all I wanted to say, and we've got some time for discussion, but I really welcome any thoughts, questions or input. Thank you. Yep, sure.
Thank you very much, Kathryn. That was really very, very exciting. Perhaps I'll start off the questions, and I can see some hands going up. I remember being at an AAMRI conference when Chris Bowen, when he was, I think, Shadow Health Minister, was was presenting. And of course, like politicians in opposition, they can promise things. And everything he said sounded very sensible about MRFF and NHMRC. Your hope at the moment is that we will be able to accomplish some of those things now with the new government?
I know that a number of us independently, but in a coordinated pincer maneuver, discussed this with Mark Butler, Jed Carney, who's the Assistant Minister for Health, pre the declaration of the election. And I think there were, the response was really, I think very positive. And the thing is, it is a good time for this because a lot of our advocacy was making sure that they fully funded the commitment to the MRFF. And now that's there. It's how do we use it better? And I do think the new government, really wants to see a much more measured approach. So yeah, I feel quite optimistic that we could get this up and running. It's just that, again, bloody COVID gets in the way, and that's, no one wants to talk about anything else at the moment.
A question from David Hume.
My career in the basic bioscience field, and I'm concerned over that career that the drive to sort of utilitarianism in the medical research area is creating a chasm between the basic bioscience and the medical applications. So in the UK, where I was for 10 years, there's a chasm between BBSRC and the Medical Research Council. And here, the advocates of the NH and MRC never really talk about the ARC. And I'm on the ARC College of Experts, and we're seeing lots of medical research related grants coming to the ARC, but they're forced to talk about what's the benefit, but don't mention the disease word. And on the other hand, if we go to the NH and MRC, the basic science is kind of submerged because you have to say, well, I'm going to cure cancer next year. So I think there's a need in the Australian research biomedical sector to actually look at that gap properly, because the real innovations, I think, are actually probably coming from the ARC rather than the NH and MRC.
Yeah, look, I agree absolutely, completely. And in our discussions, we have talked about, you haven't ignored the ARC. It's just that the ARC has, also said it, can't be applied to medical research. That is in those, as you say, you can't mention the disease word, and it's also, the other difference is that it's administered through Department of Education versus Department of Health. And so from the Health and Medical Research Institute sector, we've tended to focus on Department of Health. And the other thing is the ARC rule is you have to be university affiliated. So all of that said, that's why we've taken the approach, first of all, to look at NHMRC and MRFF. But I think the overall goal would be if we could get a whole of sector approach, and then that involves the ARC. But from the university perspective, they're not keen on opening up medical research institutes to be eligible to apply for ARC funding. So that's where the divide is. It's not that we're disregarding the ARC, but from the Medical Research Institute perspective, that's not university based, we're not eligible for ARC funding. So it was starting, I agree with you, but we had to start somewhere. And from our perspective, the advocacy is very much with health versus education.
Next question is Mayor Gandhi.
Thank you. That was a great talk. You talked about new funding into the NHMRC and the MRFF, but the previous government also have created schemes for a lot of new funds that encourage research in the broad research sector to be more commercialized. And one of the frustrations I have is it's actually very hard to access or even know how to access, particularly in the health and medical research sector. So my comment really is when you talk about novel funding schemes, I think part of it has to be to help us access some of that commercialization, which I think is important for both the basic science that David Hume talks about, but also translation.
I couldn't agree more. The other thing that AAMRI is doing in that space, so it's you know, where advocacy is in different areas, and when we're talking about our federal government and the Department of Health, for the same reason that I was just talking about NHMRC and MRFF, that's very targeted in one area. The other thing that AAMRI has very much done, though, is bring together the business development officers of all the different institutes to share expertise, to also look at what we can do back of house that promotes the accessibility of our researchers to partnerships with industry. And it's something I must say I didn't really realize till I became president of AAMRI, that a lot of the work that's done by the central office is bringing together around different areas our operations. You know, there's a piece of work at the moment to look at indirect funding. I mean, because that's the other big struggle that we have is how do we get, the MRFF currently has no indirect funding or indirect costs funded. How do we describe what we spend our indirect funds on? How can we advocate together for there to be improved funding of indirect costs? So, and then from the HR gender equity perspective, we work on that. From the data security, you know, foreign intervention. So we work on that as a sector to try and bring together the collective expertise so that as a group we can then advocate and intersect. So with the appropriate people to get those sort of partnerships happening. So that's why the input into AAMRI and particularly into the central office is useful, because we now have networks around the country of all of that expertise, and we're really sort of sharing and making freely available what we learn from one institution to another. And there is, I think, real power in bringing all of that knowledge together, because some institutes are much better at business development than others. And I was just hearing about the great work that's going on at TRI and the expansion in that space this morning.
That's certainly one of our preoccupations here, not just the
Yes.
medical translation, but also commercialization
Yeah.
and startups. And, you know, one of the things we heard in a talk earlier today from one of my colleagues was about how, you know, biotech is really thriving in the US, such that, you know, postdocs are getting recruited out of the research institutes into biotech. You know, presumably that is one angle that politicians would like the sound of, you know, that we can actually generate not only new medical products and health improvements, but also, you know, economic activity through.
Oh, absolutely.
And,
It's
and
a
possibly,
huge part of the positive message.
and possibly one area in which Australia lags behind. Right?
I absolutely
There's
agree.
certainly room for
Yeah.
improvement. Scott.
So, Kathryn, thanks for a great talk, and also for coming to Queensland as your first interstate visit. I mean, many of us as researchers in Queensland look with envy to Victoria, but the area I was interested in your talk, you talked about, was the contribution to health and medical research that state governments can make. Can you tell us a little bit about the interaction between the MRI community and more broadly health and medical researchers and the Victorian government, and what we can learn about that interaction here, because we seem to probably be not so interactive, particularly with the health department here in Queensland?
I think one thing that we've done that's been very useful in Victoria, and then is happening in other states around the country, in New South Wales and Western Australia, and it's high time it happened in Queensland, is we've brought together state groups, I can't remember what the exact word is, chapters, that's the word, state chapters of AAMRI for the specific states. And the point of that is then we have the collective within our state of Victoria. I'll give you the Victorian example, for us to advocate to state government, which let's face it, is funding the hospital system, and is also they're intercompetitive with other states. And there is, how do we attract funding for something to Victoria versus, to Queensland or to New South Wales. So it's really making sure that we, again, doing that advocacy where appropriate at a state level, because your state's really going to want to invest in industry partnerships and commercialisation. And that's certainly what I know the Victorian government is interested in. So, and the relationship, it's changed because there's now a Minister for Jobs, Precincts and Medical Research in government, who is an amazing advocate. But we're also making sure that we retain our strong relationships with Department of Health as well. But it means there is this constant dialogue. Victoria has a Health and Medical Research Scientific Advisory Committee that we all work on. Vic AAMRI, which is all the Victorian Medical Research Institutes. We collectively advocate to government in terms of infrastructure investments, and very much have brought together all of the institutes so that our back of house talks to each other around business development and industry partnership. So it's a really good way for when there are things that you want as a state to bring that grouping together. And then what we've done in Victoria is we pay an extra sort of fee so that we have a Vic AAMRI specific person, and we're sometimes getting consultants to put in business cases, for example. And that differs from state to state chapters, but then we share our experience at a state level, because if we learn something about how we can suck up to the Victorian government, we're never going to be able to suck up to the Queensland government, but you guys can. And we are happy to share, all of the different things that we've put forward to government, what's failed, what's usually failed again in terms of getting increased infrastructure funding. But it's great. We share that learnings between the states. So I'd strongly recommend that get hold of Fabienne and you really look at how you might bring some of the institutes together from the Queensland perspective. I think it's great for the state.
Next question, Nicholas Haas.
Yeah, thank you very much. As far as I understand, Anne Kelso expects something like $940 million this year. Oh,
I'm having trouble hearing from the floor. You just speak up. Yep.
As far as I understand, Anne Kelso expects $940 million this year, NHMRC funding. And you said it's you were bold by asking for $2 billion in 10 years. So I was wondering, is it bold or is it realistic? And don't we need $2 billion now and maybe $3 billion in 10 years?
Yeah, it's basically we decided to be bold. And there certainly during the Wills Review during 2000 to 2010, there was a doubling of investment in health and medical research. I think the main thing is that now that the MRFF is fully capitalised, NHMRC has not received any real additional funding. And so what we'd really like to see is that there was an equivalency in that investment from the NHMRC perspective. And if we could combine that with a coordination of funding across the two funds, the part of the discovery pipeline I worry about the most is the basic end of the spectrum, and discovery research. At my institute, we have the whole gamut of research, and that's certainly the area that I worry about the most, particularly from a workforce perspective, where our clinician scientists always have something to fall back on, or so it's a different issue, which is usually time and protected time for research. But to me, making sure that we've got that continuing very deep investment in discovery research. Otherwise, it's so short-sighted to just keep funding translation and commercialization at one end, and starving the discovery pipeline at the other end. Because if we keep doing that, we're going to have nothing to translate or to invest in 10 years' time.
One more question. Aideen McAnany.
Thanks so much, Paul. Thanks so much, Kathryn. So I'm really interested in this initiative that AAMRI has with WISP on respect in research and looking at that sexual harassment awareness and prevention. And I think it's a wonderful initiative. I wonder if you'd like to just speak a little bit about it.
Yes, it is being run out of WISP, and it's being co-funded with AAMRI. And what we're doing is bringing together, and again, it's one of these networks of the back of office networks that we pulled together around the country of particularly our people and culture, from the people and culture perspective. And it's been really successful, I know, in our gender equity, diversity and inclusion groups that we've brought together. But now we also talk around research integrity, but then this is around sexual harassment and respect and behaviour that also takes into consideration the respect of diversity as well. So it's an activity that is being coordinated through WISP and has been funded through our Victorian government, but that we're going to take more broadly. So it's again that sort of, I think the benefit of the AAMRI model is that we, having the state, the central control, so to speak, but then the state chapters, and that we share resources around the country, not just on advocating for our scientists and clinician scientists and our researchers, but then really looking at the power of the work that we're doing back of house as well. So again, these things I really encourage you to participate in, and all of that's available on the website. And I think that hopefully as things open up more, we'll also have sort of AAMRI roadshows around the country. I guess this is probably the first of those.
That's great. Thank you. I think we have to wrap up. I'm sorry, but thank you so much for all the very interesting questions we have. Thank you, Kathryn. Most of us here will have appointments in universities, so we're sort of very fortunate. We have foot in both camps, both in the university sector and in AAMRI through TRI. But I think, AAMRI, as you said, I think is probably unique internationally in terms of an organization that's advocating on behalf of all the medical research institutes in the country. I've seen myself about how important that is. The ministers always come to the conferences because it's very important to them to hear what AAMRI has to say. And we're very fortunate to have AAMRI advocating on our behalf. And I'd like to thank you personally for your leadership of AAMRI and all the work that you're doing on our behalf. So thank you very much.
That's a pleasure. Thank you. But it's true, and